we've all made great strides in reducing our emissions, and we all have a long ways to go to get, to 50% by 2030 and, net zero by 2050. But if you compare our emissions across the campuses, we're all within, 5 or 10% of each other.
If there was like an end goal at 2030 and somebody got to say that they're the most sustainable, I feel like that would be something to shoot for. We would probably want to win that. Hi, welcome back to The Vitals. I'm your host, Leslie Schlachter, a physician assistant here at the Mount Sinai Hospital. And on this episode, we're discussing sustainability and climate change and their relation to healthcare. Specifically, how Mount Sinai's sustainability initiatives are reshaping the future of healthcare, from energy-efficient infrastructure and waste reduction to sustainable food systems and supply chain innovation. To discuss our initiatives, we're joined by Dr. Moy Trin and Carlos and Colin from our supply chain and infrastructure and energy team, all of whom are sustainability and climate experts here at Mount Sinai. So you guys all do completely separate things, but towards the same goal, right? Mm-hmm. Essentially. So you're an anesthesiologist. Mm-hmm. You work 4 days a week as an anesthesiologist here, correct?
Correct.
Okay, and then 1 day a week for sustainability.
Correct.
And you are energy and infrastructure, and your supply chain.
Correct.
What does that mean to people outside of a hospital? Even in the hospital, I don't even really know what that means. What do you guys do?
So from my perspective, I'm responsible, or our team is responsible for the procurement and the delivery of all the supplies that go out throughout the medical center. So whether it's the stuff that you use, the robots that you use, we procure it, to the supplies that are used in the actual cases.
Okay. So I, as a surgical PA, I already have 100 questions. I'll put them on hold, kind of like when we use disposables and when not. And for you, you are energy and infrastructure. What does that mean?
So I'm responsible for Mount Sinai's built environment, which includes our buildings and the equipment inside of it, including the energy that we use.
So really, like the building as a whole, all of the rooms, and how, like the electricity and how it functions is you, and all the stuff that we generally use is you.
Correct.
Okay. And then where do you come in?
So I'm the clinician in the room. And so my role is actually to try to bridge some of these gaps and the silo. So we are the end users in the operating room. We take care of our patients as the clinician on the floors, in the ICUs, in the ORs, and outside the ORs as well. So I kind of represent that end and trying to connect the supplies that we use, the energy we consume, and how we can actually decrease our carbon footprint clinically. Because we use a lot, and we use it to take care of all our patients. This is why we're here.
How did you find this role? Like, did you just wake up one day and think, I want to be involved in this? Is this something you've always been passionate about?
I've been passionate about sustainability for a while, but it just started off as something quite small, to be honest with you. So I started off just doing recycling in the operating room because I saw a need for it. So I was in the OR, and I think just like you've seen in the past in the operating room, we go through a tremendous amount of supplies. Mm-hmm. So I do open hearts, and so we open up a ton of packaging material. Single-use plastics, a lot of that. And before we even started an open heart case, I remember this very vividly, we'd already filled up 3 big canisters, I think they're like 30-gallon canisters, with nothing but packaging materials. And the patient hadn't even entered the room yet. Yeah. So that just speaks to the amount of waste we generate in hospitals. And so that's actually how I got started. I started learning more about sustainability, and then I started a recycling program, a peri-op recycling program on the 3rd floor in GP3.
When did you do this?
I would say probably in 2019.
So for all of you guys listening, when you think about going to the hospital, maybe being a surgical patient or seeing your provider, every time a patient goes into the operating room, we have to set up the tables for all the equipment for anesthesia and then everything for surgery. And all of the supplies that we use have to be sterile for the patient, which means they have to be wrapped in a wrapping and then covered in a plastic wrapping. And typically all of these supplies are some form of a plastic. And to open up everything, put it out, and use it, it fills, I would say, 5 30-gallon trash cans easily per case. And so you think about that, all the patients here in one day at Mount Sinai, all of the hospitals within our system, and then across the country, just in one day, it's astronomical. So knowing that that's kind of what it looks like here from like just even a surgical perspective, but across the hospital, what's the mission of the sustainability program? Does it have a name?
I think we're a Sustain Mount Sinai, right?
Okay.
And
what's the mission?
Our mission is to try to decrease our carbon footprint from delivery of care.
Okay, and so far, how have you been doing that?
Well, collectively, I think we're on target to 50% reduction by 2030.
What would you say have like been the biggest moves that you've made so far? Like logistically, what are you doing?
So we measure our carbon emissions in a couple different ways. We divide them into Scope 1 and 2 emissions, which are primarily energy related, and we reduced that over the past 2 decades by 30%.
How?
First and most significant reduction was we eliminated all use of heating oil to heat our buildings, which that's something we did 15 years ago, and that reduced our emissions significantly. We've also grabbed a lot of low-hanging fruit that's in low-hanging energy efficiency projects, like converting your lighting from older style fluorescent incandescent bulbs to LEDs, improving our HVAC system controls so that we can turn off the HVAC when the spaces are unoccupied. We've installed advanced real-time energy management controls, which allow us to find anomalies in the way our systems operate so we can reduce wastage in that manner. So those are kind of like the low-hanging fruit that we've grabbed, and now we're looking at much more complex projects to get the next 20%.
So if there was like an old house, let's say I lived in an old house, which I don't, I live in an apartment, but if I wanted to upgrade it to make it more efficient, I maybe would check my electrical, my plumbing, check my windows, I might need new windows. What are special things about a hospital that are just different than standard? You know, I'm sure improving efficiency, especially energy-wise, is very different for a major hospital.
Yeah, the concepts are the same, but we have added challenges being a hospital. So the first is that in our ORs, for example, we require very large amounts of air to move through these rooms. And in the winter, that means we're moving 20 air changes an hour through an OR. That means that the air that might be 5 degrees outside, we have to heat to, say, 68 degrees, which requires an enormous amount of energy. Mm-hmm. That's much different than your house, where the air changes might be 0 or 1.
Right.
But there are similarities, too. So, for example, when we want to make a new building, we want to electrify it, make it more efficient, we use heat pumps and variable refrigerant flow cooling technology, and this is not that dissimilar from installing a heat pump in one of the rooms of your house that so you can turn off or eliminate your gas boiler in the basement.
You said how many years has it taken you to get to where we are now from when you first started this?
We started in the late 2000s, so it's been about 15, 16, 17 years, and we still have a long ways to go.
And I can imagine this is a very expensive project.
It is.
To do the right thing.
We try to work on it, taking small steps. So, for example, recently we opened a new AI research building at 3 East 101. That building was a former nurses' residence. We renovated it, and we replaced the HVAC system as part of that much larger project. So it's generally much more palatable and realistic to add, say, 5% to the total cost of a project and incorporate these sustainability measures than it is to say, hey, Dr. Carr, I need $2 billion to decarbonize our health system.
Right.
It's just not realistic, financially or from any other perspective. So by tackling it on a building by building or project by project basis is the way to go. Kind
of just like optimize as you go.
That's right.
Yeah. And what about from the supply chain perspective? Is it like the same concept, or can you tackle? Are you like going department to department or floor to floor? How does it work to
No,
optimize
it's more globally. So we're dependent on a lot of different things. Like just using your example of all that packaging that gets opened up, right? And so there are certain things that we could do. Like there are custom packs where you could put more stuff in there that are single sterile that don't have individual packaging. The challenges with that is there are 30 different physicians that are using that, and everybody wants to use something different.
Right.
So those are the types of things that we kind of grapple with. But from our perspective, what we try to do is we're doing more reprocessing. So there are vendors that are now you buy a single sterile item, and they've gotten FDA approval to do reprocessing. That's been going on for a while. We've expanded on that. Our par levels, we're try to get it more accurate as much as we can so that we're not over ordering. So our things, because they're not as expensive as this type of stuff that Colin is doing to do, ours is more on a global basis than as opposed to department by department.
Just like pure volume.
Correct.
When decisions are made, I'm sure you can appreciate this from like a surgical perspective. When decisions are made for instruments, like whether to have something that's disposable or not disposable, how much is sustainability thought about in that versus just pure cost?
Well, actually, to be honest with you, the number one decision of those types of things is usually with infection control.
Okay.
That's usually the first predominant, because if you're going to be using something reusable as opposed to disposable, then you have to have the proper resources in SPD. You have to make sure that all these things obviously are cleaned the proper way. And so that's a big part of it. I know one thing that is near and dear to Dr. Trent's heart is disposable gowns versus reusable gowns. We used to use reusable gowns. We've gone to disposable. Infection control is not a big fan of going back to reusable, so it's those types of conversations that we have.
What is your thought on that? What do you want?
So I'll be honest, what we were looking at wasn't actually reusable gowns in the operating room. We're considering it as a potential trial in the ICU for patients or neonates that need some isolation. So it's not a sterile environment that we're thinking about at all. But it could also reduce the waste. I want to take it a step back a little further, because we're just like shooting questions here, and it's great. I love the convo. But I just wanted to bring it back a notch. Yes, we're working on various projects, but there's also a strategic plan here. It is not that we're just gunshotting everything. So in 2024, we actually figured out where all our greenhouse gas emissions were coming from. So we completed a full inventory of our greenhouse gases. So now we kind of have a sense of hotspots. Yes, I'm so grateful for Colin and all his work. He's been doing phenomenal work to decrease Scope 1 and 2 emissions. As he mentioned, these are our energy-related emissions. The bigger part of our emissions for our entire health system, though, comes from Scope 3, which is our supply chain. That includes our medications, our medical devices, our food, our waste, employee travel. That's the bulk of our emissions that we're working on right now. And so we're trying to target these things as if it is feasible. So for instance, what we've been working on is some of the pharmaceutical agents. So my work in anesthesia has been trying to remove some of the most impactful medications. So for us in 2023, we before this in 2021, we had a bunch of QI projects that eventually what we did was we removed desflurane entirely from formulary. It's one of the agents that we use to keep patients asleep, but it's 2,500 times more efficient at trapping heat than CO2. We have a lot of other medications out there that are available to keep patients asleep that are equally safe, equally efficacious, but with much, much lower carbon footprint. And so this is the kind of stuff that we're talking about. We're talking about exchanging something that still gives us quality of care, keeps our patients safe, does what it's supposed to, but with a lower carbon footprint. And so that's one of the initiatives that we've worked on. And then the other part is getting rid of waste. We discovered that our nitrous oxide, 90% of it, of our purchased nitrous, was actually never reaching the patient because of the delivery system.
Wait,
so it's being,
how does that happen?
So it's being piped from these large tanks, cryogenic tanks, and there's loss along the entire system due to the nature of nitrous oxide. So by removing these tanks and actually just delivering the nitrous oxide at the point of care, which is in the operating room, in tanks, smaller tanks now, we've eliminated over 90% of the waste.
Wow.
So these are the things that we're talking about, that we're thinking about critically from the clinical side. And then when we talk about supply chain, these are the things that we're actually interested in implementing. So that we can decrease our carbon emission where it's not actually being used and not being helpful.
How do you actually evaluate our carbon footprint? Like, what does that look like?
There are certain products that we understand the carbon emission of that product, specifically some medications. But in order to understand a carbon footprint, it is looking at all the things that go into manufacturing of a product, as well as use and then disposal of that product.
Okay.
So you have to do what's called a life cycle assessment to really understand this. Or a life cycle inventory. This is another way of looking at cradle to grave emissions from a product. as you may understand now, given the amount of products out there, it's not exactly easy to get product-specific carbon emission data for every little thing, every little drug that we use. So what's acceptable right now is what we're using as an input-output, I guess, cost-based analysis of carbon emissions. So we use that to estimate the things that we didn't know about in 2024 when we were inventorying our greenhouse gas emissions.
Yes, in general, measuring the Scope 3 emissions is much more difficult than energy-related Scope 1 and 2 emissions, which we generally know exactly what our emissions are.
You could look at that on a
we
gauge,
have utility
right?
meters,
Yeah.
and we know generally how much carbon it takes or how much carbon is being emitted when they generate electricity upstate. So that's much more defined than the work that Carlos and Dr. Trin are doing.
What's the green team?
At Sinai, sustainability started off as grassroots. And so the Green Team basically embodies that still to this day. So it's basically a forum for all hospital employees to join if they choose to, so they can work on sustainability initiatives. So they can join these meetings, bring in ideas, and we try to operationalize what we are able to. And then we work with the team there. Obviously, with 7 hospitals, you can imagine that these meetings get really big. And so what we try to do is break it down to smaller groups and work on smaller projects together.
Like a work study group.
Kind of, yes.
Yeah. So the green team kind of preceded this sustainability project. It kind of was like getting it going a little bit from the grassroots level?
Yes, I would say.
How many people are on the sustainability project team?
I would say it's not really a defined team. We have a few key leaders that are involved at high level. We also have a sustainability committee that includes many of our executive leadership at Mount Sinai. But there's many people, including, say, Pat Ortleb from the food and nutrition team, to we have an actual energy team that works under our department that it really gets into the nitty gritty. So it's a pretty wide group of employees here at Mount Sinai.
Mount Sinai was one of the first hospitals to sign the, I think this is New York SIF. Is that what the NY stands for?
Yes, so New York State Insurance Fund.
The Climate Action Pledge. What is that, and what does that mean?
So the New York State Insurance Fund Climate Action Pledge is actually a really unique and innovative pledge. So Sinai signed on to it in 2024. And basically what we're doing is we're pledging to decrease our emissions by a certain number, so 50% by 2030. And the aim is to achieve net zero by 2050. And what they've done is they've tied a financial incentive to climate action. What it's done for us as a health system, it's actually really accelerated our sustainability program by making a business case for environmental stewardship. Mm-hmm. And so I talk about it a lot because I think it's so unique and it's so impactful. And it's also an example of how when we do the right things by our patient, by the community, and for the environment, and for our staff, it still makes business sense because we're still able to save money and there's a financial incentive behind it. It's also a real example where insurers and healthcare can actually partner to progress or to work towards climate action. So it's a lot of the commitments that we've made were very similar to our other commitments. So one was to complete our inventory of greenhouse gas emissions, which we did, and then every year to decrease our emissions, develop a strategic plan, and then report on it annually on our progress. So that's things that we've done with other programs. Mm-hmm. But the thing that was different was that they tied it to $1 million.
That's nice. So if sustainability was a competition here in New York, and all the New York hospitals were participating, who would be winning?
Well,
that's a tough question.
To be honest, I think most of the major hospitals are at kind of the same point in this journey. We have our regular meetings with our colleagues at New York Presbyterian, NYU Langone, MSK, Northwell, Monty. I could go on. But they all have programs similar to ours. They have all invested in energy efficiency. We've all made great strides in reducing our emissions, and we all have a long ways to go to get to 50% by 2030 and net zero by 2050. But if you compare our emissions across the campuses, we're all within 5 or 10% of each other.
I'm just saying that like we're pretty competitive. If there was like an end goal at 2030 and somebody got to say that they're the most sustainable, I feel like that would be something to shoot for. We would probably want to win that, right?
Of course.
Yeah. Okay. So I just want to go back to the green team thing because it seems like you said they brought ideas to you. What were some of the best green team ideas that they brought to you that you guys were not thinking of?
So one of the things that we started was actually a virtual marketplace for equipment, office supplies. So the advantage of having a virtual marketplace is that there are products that people can't use, but if somebody else from the health system can use it, why not? And then it also decreases our carbon emission because we're not purchasing new.
Like give an example of something.
So, for instance, like a chair.
Oh,
now
yeah,
you don't have to buy a chair.
Isn't there like a warehouse where you can just like get what you need?
Mm-hmm.
That's really nice.
Yeah.
What's another one?
One of the employees wanted to carpool. And so we have 7 hospitals. So you can imagine that's a little complex trying to create a carpooling program, but we're trying. We're figuring it out right now.
Like carpooling outside of just the shuttle that we already have, like a separate system?
Yes, we're talking from home. Somebody was on Long
nice.
Island, and they're looking for somebody else on Long
You might
Island
want
to
to talk
drive in.
to HR. I think HR already has one.
I think it got taken down during COVID.
Maybe that. Yeah,
So that's why we're trying to start it
bring
back up.
Okay.
That's why
Makes
you need
sense.
like somebody from every department talking in a room so you're not like doubling the efforts.
Yeah.
What about from like your standpoint from Big Energy? What were like some of the best ideas, or is that not really a grassroots thing?
We have some pretty big ideas about where we want to go with sustainability. So one of the kind of leading edge technologies is heat recovery. So that's taking our waste heat from this room, for example, which is probably warmer than we like it to be,
Yeah.
and using it to heat our building instead of just exhausting it to the atmosphere.
Or to go into the ORs where we're cold?
That's exactly right. So that's we're already doing that. We have a great project going on at the Hess data center where we're collecting heat from our supercomputers, if you will, that the School of Medicine uses for research, and we're going to use that heat to heat the Hess building all year round. So it's good because we can use this heat recovery chiller to cool the computers, and it's also good because we're going to burn less natural gas in our boilers because we won't have to use natural gas to heat this building anymore. So that's kind of the cutting edge. It's just a matter of these projects take a lot of energy, they take a lot of resources, and they take a lot of capital. So we just have to tackle them, one at a time.
Do you participate in all new builds across the system, or do you have people at other sites?
Yeah, we look at things from a system-wide perspective. So generally when we're either renovating a unit or renovating an entire building or building a new building, our team is involved working with the architects and the engineers and the clinicians and our business team to incorporate sustainability features into these projects.
Mm-hmm. So let's just take an example. My neurocritical care team is on KCC 9, and we were just booted out again over to Annenberg 8, and they're going to spend the next couple of years building and changing the unit. Is that just like standard build, or is there sustainability thought that's going into that?
Yeah, so that's part of our Tisch Cancer Center project where the health system is investing in this older 1950s era building, and we're going to convert it into a modern 72-bed cancer hospital, including the neurosurgical ICU and the cardiac ICU. And as part of that project, we're going to replace the old uninsulated masonry facade with a brand new curtain wall, which will be much more energy efficient. It'll be a much better environment for our patients, much more comfortable, much better light. And we're also incorporating other features, like we're replacing the 100% outside air handlers with brand new air handlers that have energy recovery features. So that project, which is it's not it's not a sustainability project. It's a project to provide more cancer care to our patients, but we've incorporated these sustainability measures into that project. So we
you're
don't
just
have
sustainability forward.
That's right.
Right. Do you, like, going back to COVID times, I remember, like, we had to think about, like, how we were ventilating and all of those things. Is that's also built into it, kind of the things that we learned through COVID?
Yeah, to some extent. I mean, one of the things we learned in COVID is that a very high level of filtration is very protective of our employees and staff. So when COVID first hit, there was a tendency. It was like, oh, well, we need 100% outside air. We can't recirculate any air. Mm-hmm. Well, after some studies, we found that that's not really true. Like, you can achieve your infection prevention goals by using high levels of filtration. So we're implementing that throughout these projects. And we're also, we design these systems with as much flexibility as possible. But to be honest, there's only so much. If it's 98 degrees in the summer and 90% humidity, well, I can't treat 100% outside air and distribute that throughout the hospital. We won't. We just can't do that. And the same thing in the winter. And it's really not necessary either.
A lot of the projects that you guys are talking about when we say sustainability is like for the better of the world, the climate. But how do all of these actions better the patient, better for the actual patient and their care?
Well, the simplest example is eliminating the burning of heating oil in our buildings. That eliminates a lot of particulates, a lot of other other kinds of air pollution for our patients that live, say, right outside of or right downwind of our hospital building. So that's a very simplistic approach, or example, but that can be applied on a much broader scale. When we reduce our burning of even cleaner natural gas, we reduce the emissions out of our facilities that potentially impact some of our patients and our employees.
Mm-hmm. So I think also there are direct effects and there are also indirect effects, right? So the direct effects are much easier to see, right? Air pollution, heat, right? Extreme weather events, right? And so you see those immediate effects. So with extreme heat, you can have asthma, COPD, heart failure exacerbations. Right. That's very direct and you can see it. But there are also indirect effects, right? So we're very lucky. We live in New York City, and so we haven't really had this. But other states, such as Texas or Florida, they have hurricanes and floods, right? And during that process, yes, hospital facilities are affected by it. And it's not just the patients in the hospital that need to be transferred out immediately, but it's also what happens afterwards, because those areas, they can't actually take care of their patients there, right? The hospital facilities are not 100% functional. And so their communities don't have access, basically. And so that's part of the work with sustainability, is making sure that we're resilient, that we can bounce back and we can take care of our patients even when these things happen. But moreover, if you're reading the literature, you're seeing an increased number of reports and studies out there with nanoplastics and microplastics getting into our bodies. Right. So plastics, they break down into smaller particles, but they never completely disintegrate. They're getting into our food chain, our water, and we're drinking it, we're consuming it. And one of the studies from 2024 in the New England Journal of Medicine looked at carotid plaques. So basically, you can have formation of plaques in your carotid artery, which is the artery that brings blood to your brain. And these were patients who didn't have symptoms. They came in and had them removed. When you looked at it under the microscope, the patients with nanoplastics and microplastic had a 4.5 times higher incidence of MI, stroke, and death. So there are associations.
Are they like just creating vessel wall damage just from being in there?
I think it was more an association study. Okay. We don't know exactly what the mechanism is, but it's affecting us long term in indirect ways that we are not seeing. And certainly there are studies looking at plastics in placental tissues and heat shock proteins. So I think that it does impact human health, and we need to be thinking more globally and long term.
So that's kind of like what you were saying before about when I asked you about disposables versus reusables, and you had said it's an infection control thing, but it also, like, that's acutely, but it also long term could be on the flip side unhealthy for the patient long term, possibly with all the
Could
plastics.
be. I mean, those are
Yeah.
studies that would have to be done. But yeah, I mean, all of those things. Cost is definitely not the only factor that we consider when we're making these decisions.
So how does the hospital work when it comes to like actually buying all these products? Is it just based on like what our typical use rate is? How do we share with other hospitals? Is there like a reusing program?
From a sustainability perspective, one of the things that we've been trying to do more is when you use the example of sharing with other hospitals is to donate more. We just closed BI, right?
Right.
And so one of the things that we're doing there is we've brought in not only organizations like AFIA that then they take the supplies and the equipment that we give them and they take it to other countries, but we've brought in other hospitals that we partner with for them to get supplies, like the chairs and things of that nature
Right.
that we're going to throw out so that we don't put it into the landfills. So we've been doing more and more of that. We even actually have partnered with an organization that, because not too many people will take expired products, but we have one or two organizations that will. And so we've been partnering with them so that even products that's expired that you can't donate or another hospital can't use, they'll take it and they're able to use it. And so we've been trying to do those types of things as well.
When you look like item per item, and this is kind of like a good both of you question, if you were to look at cost of a disposable, one-time use, throwing it away, and compare that to a reusable that has to go through SPD and chemicals, emissions for that, something kind of obvious and basic to you guys. How do you compare that side by side? Forget about infection control. How do you make that decision?
Well, from our perspective, I mean that's an easy enough analysis, right? Because let's say the reusable item is $1,000 and the disposable is $20, right? So you start there, and then from there you start building on. Well, what are all those other costs that you just mentioned that equal up to that, right? And how many times can you reprocess the $1,000 one? So those are the types of analysis that you do from a financial perspective, and then you get which one makes the most sense. And then you start on top of that. If it's pretty close, then you start adding on sustainability and everything else that goes along with it.
How often are we doing that for the majority of the products that we use? Like reassessing what the best option is?
Well, I mean, I would say that the more reprocessing that we're looking at are things that have FDA clearance, because then you also have legal implications. If you're like, first of all, when you talk about instrumentation, there are certain things that obviously, like an LMA or things of that nature, that you could look at disposable versus reprocessed, right? So those are types of things. But then you have to start looking at, and we do look at those, and we go through value analysis, and we've looked at those things. A lot of times is the amount of resources that are needed to be able to do that in SPD
Right.
compared to them having to be able to re-sterilize all of the products that they need for the OR.
Right.
Excuse me, for the OR. So those are the types of things we look at. But a lot of times, there's not like thousands of items out there that you could say I could do one or the other, and so we have to do this massive look at. More of what we're trying to do is things that have an FDA clearance. EP is a big area. So like EP has like ablation catheters and things of that nature.
EP is electrophysiology.
Sorry, I apologize.
Yeah.
So electrophysiology.
And SPD is sterile processing department.
Thank you. And so there are ablation catheters and ice catheters that you can reprocess, right? And so that's where we're focusing a lot more on, is being able to get those purchased because they have 510K clearance. And not only do they save money for the organization, but obviously from a sustainability perspective, it also works as well.
So kind of like you want to find sometimes the lower hanging fruit, although it might be easy, it doesn't make big energy changes. So you want to focus on the bigger energy changes.
So I'll give you an example actually about reusables and single use. This is actually a project that Colin knows about because I've been working on it for a little bit. And that's the laryngoscope. So we know the carbon footprint from the laryngoscope, the disposable one, is much, much higher because of all the manufacturing that goes into making a single patient use laryngoscope.
I didn't even
versus
know we
the
had
reusable.
single-use laryngoscopes.
That's all we have.
Those are single use?
They're all single use. They get thrown out.
That's terrible.
Tremendous amount
They
of
look
plastic.
very not single usey.
No, they're single usey.
Oh man.
They cannot be reprocessed. They cannot be recycled. They just go straight in the trash.
That's terrible.
So we're evaluating a reusable handle, which decreases the carbon emission from the handle by about 20-fold. And so So we can do that kind of analysis and then extrapolate to cost-benefit analysis, and you'll see that eventually, when you look at extrapolate that to a year, 2 years, 3 years, assuming that you don't have loss along the way, that there's going to be a few $100,000, a few $100,000 actually, when we did the math, cost savings, and then obviously, you also have to get it through infection prevention, and we have to work within the team and within the health system to be able to make the workflow be something that the health system can sustain.
Wow, I'm so shook by that, by like the laryngoscope being single use. Yeah, because they look very expensive. There's batteries in them, clearly.
The batteries get thrown out.
Yeah. Oh, that's too bad. What's another example of something like that?
This is something that we recently did, was the non-invasive cuff. I'm sure Carlos was involved in that too. There's a single patient use non-invasive cuffs. They get thrown out after the patient
Like
leaves.
a blood pressure cuff?
Correct.
Okay.
And then due to supply chain shortages and other things, we ended up switching over to reusables. So the manufacturing from the reusable and reusing it more than once with patients ends up actually being much, much lower carbon footprint than throwing out. So if you are able to reuse the non-invasive cuff for 10 patients, you're actually saving yourself 10 non-invasive cuffs that are being thrown out after each patient.
So when I'm on Amazon and I'm ordering packages, there's always an option that says, like, do you want everything as soon as possible, or do you want a lower carbon footprint and everything to come in one order, even if that's later? Are there options like that with our deliveries for things here at Mount Sinai? So there's like less trucks delivering things?
So what we normally do is for all our general med-surg supplies, we have a prime distributor, kind of like an Amazon. They're called Medline, and we get all of our med-surg deliveries from them. It's still a lot of deliveries. I mean, we get at Mount Sinai Hospital, we get 4 trucks a night that comes delivered for all the supplies that we use, and that happens 5 days a week. And then UPS delivers twice and FedEx delivers twice. So we get like 4 deliveries a day from that. So one of the things that we're trying to do is look at how we can consolidate even further to try to get less of those trucks to come in.
So I would imagine you have to, like, in order to do that, you're kind of functioning at par levels on the floor to reduce waste on the floor. How is that supply chain communicated on what's needed to replace and how that gets back to how many trucks?
So there's a whole host of people behind the scenes that are looking at all that data. I mean, when you look at the stuff that we're ordering, it's over 1 million lines of data a year of what we're ordering. And so we have now at Mount Sinai Hospital places that instead of delivering 5 days a week, we actually now have the data and we're delivering 3 days a week too.
Okay.
So we're doing things like that. But that requires a lot of resources that are looking at all this data of all these different lines that we're ordering. Because you can have a par level of like 50 for a particular widget, and then you look and you see that you're ordering 10 a day,
right?
So that you might just then reduce the par level and maybe not order as often. So that is constantly being done to try to reduce all of that.
Mm-hmm. And then what about things like working with the technology department? I can imagine we print a lot. I wish we didn't, but we print a lot. How do we optimize so that we don't waste paper?
So we're going to what's called eventually in 2026, actually, we're going to what's called pull printing. So instead of you just printing everything to the printer, you'll have your badge and you send something to the printer, and until you take your badge, it won't print. Because what you'll find is a lot of times people print stuff, then they forget that they printed and they don't even get it,
right,
and it's still left at the printer. So those are the types of things that we're doing. We're looking at consolidating printers, having a better policy. Instead of saying everybody in their office has a printer, there's a general printer that's outside your office, and because you're doing pull print, it's still secure. And so those are the types of things that we're looking at doing there.
So when I used to work in urology, anytime I placed an order for anything or closed a note, like the after visit summary and any like MRI, anything I ordered would just go automatically to the printer. But most of the time I never give that to the patients. Like they call and get their appointments. When I moved up here to neurosurgery, I had that part of my Epic turned off so that nothing prints out anymore for me. I wonder how many people out there are just printing endlessly and have no idea to random printers.
That's a really good point. I mean, and I can't speak for DDP because they obviously do their own things. They might have already done that for all I know, but that's definitely a good question to ask them. So I appreciate you bringing that up.
Yeah. So there's kind of like the supplies, there's the energy, the infrastructure, and you're kind of like intermediary for a lot of these things. You brought up food before. That's like probably a whole separate conversation, is like how food gets in here and waste and all of that. But one more thing I'm just kind of curious about is clinical waste, right? A lot of times we have protocols for how we order things, whether it be post-op blood tests, scans, note writing, smart phrases. A lot of stuff just gets done and ordered that's not necessary. Is there a department working on that form of waste? Because that's like my carbon footprint, my emotional carbon footprint.
Yes. So as you can imagine, just kind of like the way Carlos alluded to, there's so many things, so many items, so many medical devices, syringe. I'm sure I wish there were usables for a lot of the other things.
Right.
There really aren't for
Yeah.
a lot of equipment and supplies that we have. But in terms of clinical waste, I think the best thing, unfortunately, because there's so many different departments, divisions, it's hard to be able to hone in on everything, right? So in some sense, what we really need, what we really want, is actually specialists in those areas to tell us what they need or to take up the leadership spot in there. Maybe somebody in urology can show us where they're wasting.
Right.
And where they can actually trim and decrease their carbon emission from. That's
Like a
what
lot
we're
of
hoping
old
for.
protocols that people do when you ask them why, they're like, I don't know, it's just what we do. Like especially down in radiology, those machines probably run a lot of extra sequences that just aren't needed. What's one thing that you guys have been a part of, something, it can be something small or big, that you are most proud of so far on this sustainability mission? Whoever wants to go first.
Well, I'll jump in. I mentioned that Hess data center project. We got a $2 million award from the state to support that project, so that offset a significant portion of that cost, and I think that'll be a big success from us on it.
Wow, congratulations for that.
Yeah, congrats. I would say that in terms of sustainability in our journey, so part of my journey is actually quite personal. One of the things that we talk about with sustainability, why we do what we do, and part of it is that what I want to do is be able to leave behind a more habitable world for my daughter. So one of the things that she came home with when she was 8 was, Mom, the polar ice caps are melting. What happens in the, downtown if it's flooded? And so what I wanted to talk to her about and let her know is that, yes, this is a problem. Yes, climate change is a problem and global warming is an issue, but also that you can do something about it, that she has agency. And I think that's what I'm proud of most, I guess, in this journey and this work, is that we've made something of the work. With this team, really.
Right.
We couldn't have done it without all the people that put
How old
together.
is she?
Now she's 11.
So she should come intern here. Project. Yeah. What about you, Carlos?
I would say the biggest project, though, is one that we're still working on, which is we're working with our prime distributor to develop our own warehouse, which will allow us to do a lot of this consolidation and give us a lot more of flexibility to some of the things that we're going to do. So I'm hoping that that'll get completed in 26.
Awesome. Thank you. Thank you guys so much for being here. I appreciate it.
Thank you.
Thanks for having us.
Make sure that you subscribe to our Mount Sinai Health System on Apple, Spotify, or wherever you get your podcasts.